Next speaker, Dr. Ajith Bhagawath.
Good afternoon, everybody. Actually, the previous two cases you saw where one was rotablation, second was an SVG graft. Both these cases we don't do every day. But sometimes you get into trouble when you are doing a run-of-the-mill case. And sometimes, you can get terribly dirty even if you are not fighting in the mud. You may be fighting on a matting, regular matting. This was a situation which I faced about 6 months ago. This was a 33-year-old gentleman, hypertension, obese, smoker. He had acute coronary syndrome, presented with rest pain, sweating and dyspnea, 3 episodes in previous 24 hours, and he was troponin positive. Now, this was an ECG. I apologize for the bad quality of the slide, but you can see during pain, he had ST depression in inferior leads and tall T waves in anterior chest leads. Now, I took him for an intervention, and this was, this proximal LED didn't look too tight, so I just thought I would go ahead and, stent it directly. He was fully loaded with antiplatelet agents and received 80 milligrams of atorvastatin before the intervention. Now, this was the stent which I put, and you can see here clearly that the stent is coming, the proximal end of the stent is coming in and out of the left main. And it was very difficult for me to position the proximal end of the stent at the ostium of the LED. So I thought about this, and I decided that, I had read about it, that you can inflate the balloon to 1 or 2 atmospheres to increase the profile of the stent, and with that it's easier to position the proximal end of the stent wherever you want. So that's what I did. Now you can see here that the stent is partially inflated, and this was a partially inflated balloon, and you can see that there is no contrast going distally. Now with this I could position the stent properly, and the to and fro movement of the stent went away. So I was quite happy. And when I was about to inflate this balloon and deploy the stent, this was what happened. Now I saw this on the monitor, and my balloon was partially inflated. I had no option but to deploy the stent right away. There was no choice of pulling back the stent because of partially inflated balloon. Now immediately I deployed it, and I came out, and I started CPR and started shocking the patient. This was 4:03 p.m. Now this continued for a while. This was 4:06. We are shocking the patient. Patient was getting continuous CPR. There was no rhythm, no sinus rhythm restoration whatsoever. Patient was intubated, and I went back. I thought that there is something must have gone wrong when I deployed the stent, and the only place where it can so seriously go wrong is the left main. So I went back. I just took an injection, and I saw that there was hardly any flow in the whole left coronary system. So intuitively I thought that there is either a dissection in the left main or a thrombus in the left main. The CPR was on, so I just came out and then thought over it for a few seconds. CPR was on. This was 4:08. This was 4:10. 4:12. No rhythm. Patient had received almost 15 shocks. Now I went back. I just put another stent in the left main right across the circumflex. This was about, I think the size was 324. Now when I deployed it, immediately after that there was the CPR was continuously on. There was some hope. I saw some kind of QRS complexes which I could decipher. There was a lot of epinephrine was being given, lot of stuff was given, and this was the injection, and I saw some kind of flow in the left system, so I was a little happy. There was some pressure, about 40-60 at that time, systolic. But then immediately when I saw that pressure, immediately patient went into VF again, and pressure, whatever pressure I had, started dropping, and this was the flow. Now, there was no flow in the left system. There was a big thrombus in the left main, and there was hardly any flow in the circumflex. Now, again, the CPR was on, and on the spot of that moment, I thought that this left main stent is underdeployed, probably. So I went back, took a 3.5 balloon, and dilated the left main. Now, after dilating the left main, I did a thought of thrombosuction, because I knew that I must have pushed a lot of stuff down the artery. Now, this was the final result. Patient, after restoring the flow, he immediately started showing improvement. 40, 60, 80, 100 systolic. This was the final result. And I had some time to put in the balloon pump, so I went from the left side, put in the balloon pump. This was the pressure immediately after dilating the left main. And then this was, we shifted the patient to the ICU after half an hour, and ensuring that he is stable. This was the ECG post-PTCA. There was no evidence of infarction. This was the ECG next day, looking quite good. This was the echo the next day. And this was just to make a point here that sometimes the cases which are looking very simple can create a disaster. And this particular situation where you cannot position the stent properly at the left LED ostium can be very tricky. And I would like to know from you, if any one of you has had this problem and how you solved it. But I had a similar case. I will just show you two more slides. This was a case which I just did 3-4 days ago, where it was a similar patient. This was a very proximal tight LED. Now look at the stent. This was again coming in and out. So what I did this time was, I was wiser. Forewarned is forearmed. What I did was, I pushed the guiding catheter way inside the left main up to the LED ostium. And that allowed me, that stopped the to and fro movement of the stent. And then the stent was deployed, and the final results were very good. So sometimes your previous nasty experiences make you wiser, and probably this was one of the cases. I was really lucky to get out of this situation. But I think this particular problem of not being able to position the stent at the LED ostium can be very tricky. Thank you.